So it stops blinking.
Wait.
You're gonna walk around.
Oh, okay. All right, thanks. So this guy had talked to us, he's 300 to 400 pounds. No one has really done a full examination on him because he's so hard to get off the gurney in the emergency room. So we get him off the gurney and he has this little bit of what we call a circumducting gait. He's a great big guy, so he's really hard to get reflexes with. So I got this reflex hammer that's this big. So, and he's just hyperreflexia, which is an upper motor neuron sign. Great big, very handsome looking beard, so you can't see the left facial paralysis. I don't know if you saw Tim Curry, Rocky Horror Picture Show. He's just on the front of Entertainment. You can see the hemiparesis. So he had a big stroke, which is really sad. But this guy, you couldn't tell. He was so big. He was used to moving slow, if you will. He had all this hair on his face. He had a mild stroke. And he said, Doc, you know, I woke up with this a couple days ago, but I've been so tired, I just haven't mentioned it to anybody. So when I was 36, if I had woken up with the inability to move the left side of my body very well, I might have mentioned it to someone. So his cognition is not quite there. I mean, he's hypoxemic at night is what we're assuming. And what we had seen is the great Guillaume Monod, who we just brought up, who mentioned the term apnea index in 1978. He said, you know, I followed the blood pressure of a lot of these patients. And oftentimes during sleep, the apneics have really high blood pressures, but you know, they're big people. I can't afford the great big cuffs. Maybe it's just a cuff phenomenon. So Verind and I, we started monitoring the blood pressure of these patients. And we found that they were very, very high during apneic events. And we said, and that was our question. At this time, this great big guy who goes to sleep, snores insomnia and daytime sleepiness, wakes up, no other major risk factor for stroke. At that time, we didn't think obesity was a factor. We said, you know, I think the low oxygen and the high blood pressure could have caused this internal capsule bleed, because that's where they're usually occurring. So I talked to Verind and Dr. Aboud and Alan Mark and Dr. Heisted, and we said, I think this is cause and effect. So what do you think? From this case that I've presented, A, is it reasonable to assume that this obstructive sleep apnea caused the stroke? Or B, now we all heard that stroke can cause apnea because there are breathing centers throughout the brain. Maybe stroke caused the apnea, a central kind of obstruction. Or obstructive sleep apnea and stroke were chance occurrences. Or cases like this justify prevalence studies, because this guy turned out to have severe apnea. We treated it, he got a job, he got married, and he never wanted to see us again, because the hospitals where every one of his relatives went right before they died. So I mean, he's just a good old boy and just said, damn, I feel good, I'm not coming back. So what do you think? How many people say A? How many people say B? How many people say C? How many people say D? Okay, good. How many people have seen this lecture before? Yeah, so great science begins with simple observation. Case reports are still important, but unless you're a resident or a medical student at national meetings, they're not going to let us present case reports. But this was one of the first case reports. A case report is a finding that might make sense to you, but as Dr. Mark said to me, you need to do more scientific studies. So a prevalence study really helps show association, and they're relatively cheap, and they're the next step in affordable research, data-driven statements that you want to make about a pathologic or sleep or a disease-related entity. So we did a prevalence study with Verind, and in 1992, we saw, at least published this, 24 consecutively encountered stroke patients came into our stroke unit. And of those who would allow me to do studies, just a portable study, and most of them were very forthcoming with that, we then took 27 gender, age, and BMI matched controls. Well, maybe it was the BMI, so we wanted to equalize for that, because we didn't know what cause and effect was. By the way, we still don't know what cause and effect is for sure, with an awful lot of these disorders, although they make sense to us. And what we found that in our patient population with stroke, 77% of all the men, 64% of all the women with stroke had obstructive sleep apnea. And when we compare it to the controls, this was significant to p-values of 0.01 and 6968. So there looks like there was a strong association between stroke, acute stroke, and obstructive sleep apnea. This study, as you all probably well know, has been repeated over and over and over, literally hundreds of times in the literature with every major study that's been done. But that was the first one. We're sort of proud of it because Vrind was such a smart guy, he said, you can't have anecdote. You've got to have science. So a good prevalence study, though, if you got the money, if you got the funding, if you got a reason to say at the beginning of every lecture, I have a few conflict of interests, which I don't right now, you have funding to afford very expensive cohort studies. So Dr. Redline and Terry Young is from Wisconsin, and Redline is from Harvard. They had lots of money because they're very smart people and had great presentations, and based upon the anecdote, based upon the prevalence studies that were out there, they were able to get funding to do these big studies where they would do sleep studies, home-related sleep studies, and blind themselves to the results and then follow over the years. Now, there's always those ethical issues. Underlying all these studies that they blinded into themselves was people with unrecognized diagnosis. But that's the element of a cohort study. And you have to make science with some of these disorders. You just can't be playing off anecdote, but the ethics do come in, the expenses do come in, and they were able to justify this through their IRBs. So when you followed these patients, thousands of patients over 4 to 12-year periods, they find that, and in a nutshell what this is saying, is that if you have an apnea-hypopnea index of 20 or greater and you choose not to have that taken care of, within a 4 to 12-year period, you have a risk of developing a higher risk than a person without apnea of developing an ischemic stroke, hypertension, or cardiac abnormalities, including atrial fibrillation, the big three. So that's the cohort study. It does not define cause and effect. It's risk. That's what it defines. So we know that other people have thought, though, we were thinking, well, I think that sleep apnea, because of the low oxygen, is causing a stroke. Many people say that, how can that happen? And what Vrind and I thought was maybe it's the autonomic responses to obstructive sleep apnea. And we know that autonomic elevation can raise blood pressure. And in the second part of the study, we know that people with congestive heart failure, autonomics are way up because it's trying to support this dying myocardium. So sympathetics can have positive effects, so you can still pump blood in the dying myocardium, but if you overdo the sympathetics and the blood pressure is too high for the blood vessel, it could blow out in the brain, in the heart, in the kidney, in any part of the body. So we were thinking maybe what's happening is the autonomic responses to apnea, high blood pressure. So there was a lot of things that Vrind and Hedner and others had done, but Hedner did the first studies showing this elevated microneurography, which is direct monitoring of sympathetic nervous system using a tungsten needle electrode, microneurography. What you do is you take the needle, stick into the perineal nerve during a sleep study, and most of my patients were really big, obvious apneas that we hadn't diagnosed. So we did not treat. We evaluated sure bets almost, great big heavy people with snoring, insomnia, daytime sleepiness, during diagnostic studies. So we circumvented the ethical problem, and we paid them some money, and we stuck this needle in their perineal nerve, and what Vrind did is he searched for a postganglionic unmyelinated C fiber, which is an autonomic blood vessel nerve, and it would elevate 1-to-1 with the blood pressure, and we either had an intra-arterial line in or a FiniPress. So we followed that blood pressure. And what we saw is sympathetic, and then through the clinical observation, the parasympathetic activity. When you suck in against a closed glottis, that's what obstructive apnea is. And when you do that when you're awake, you call it a Mueller's maneuver. When Vrind started doing his studies, he said, well, let's look at central apnea too, or obstructive apnea, and he just had them hold their breath. And that's a central apnea, but if they suck it against a closed glottis, so pinch your nose, and sucking real hard, you might pass out. Because what happens when you do that, when you mimic an obstructive apnea, not a central, just holding your breath, you increase the sympathetic activity, you increase the parasympathetic activity as evidenced by tachybradycardia and maybe even asystole. And Vrind did that to one of our medical students who had borderline hypertension, so he's doing the study and he's going, so we stopped the study on him because we're ethical. Anyway, so sympathetic and parasympathetic active occurs during obstructions. Heart block can occur, cardiac dysrhythmia, as I've mentioned, and then the blood pressures go way up. And in our study, 240 over 130 was the mean at the peak of the apnea. And you have also subsequent, the theory is apnea after apnea after apnea does damage to the endothelium, one of the multiple theories. White blood cells come in, something's been injured. They lay down mitogen, smooth muscle lay down, and after many years, the nighttime injuries result in daytime hypertension. So that's the thought, is sustained waking sympathetic tone. So this is a typical sleep study that most of you are pretty familiar with. And we go the eyes, then the brain, then the muscle, the EKG, then the breathing at the nose, the mouth, the chest, from head to toe, if you will. And this is a mixed or an obstructive sleep apnea. And then uh-oh. Will that go away? Well, pretend like that's not there. I was pressing the wrong button. But anyway, this is the beginning of the mixed apnea, which is essentially an obstructive. Then the chest is receiving no airflow from the nose to the mouth. And then in between, this 30-second epoch, there will be a microarousal. SaO2 is continuing to drop throughout the study. You know, the typical thing you see with an obstructive apnea. Oh, that worked. And simultaneously, so we have monitoring all over, but this is the muscle sympathetic nerve activity channel. So I didn't shove everything on one slide so you could see this. So during microneurography, this is the monitoring of the sympathetic system. The beginning of the apnea, the amplitude, the frequency of the sympathetic discharge goes crazy. Blood pressure peaks at 240/130 right here using a FiniPress monitor, and as soon as the glottis opens, returns, boom, the sympathetic activity goes over so you don't overshoot, that's what you hope, and the blood pressure comes back down. And our hypothesis was in our index case and in other cases where this associates with seeing that this blood pressure may sustain too much or be too high, and it can cause damage to the heart or the brain. Alrighty. Now, some people said, but you know, they've shown this for years. If you have a stroke of your respiratory centers, a stroke could cause an apnea. We know Ondine's curse, central alveolar hypoventilation of children. Little kids who are born without the respiratory centers for automatic breathing in their brain, just fine during the day, and they go to sleep and they die. So I think the famous kid in Great Britain is like 18 years old. He's never been able to breathe without some sort of respiratory support his entire life. And he's doing quite well. But he has other neuronal laydown problems that occurred during development as a fetus, including the nerves to his gut, so he has Hirschsprung's disease too, and he has a really funky diet. But a happy kid who just can't breathe automatically. So it made sense to say that maybe what you're seeing is not apnea causing stroke, but the stroke hit a respiratory center and it's the sequelae of a stroke. So we know from animal studies and from autonomic human stroke at a time studies that there are these automatic respiratory centers in the medulla of the brain that are dependent on good neuronal function. And these areas we've seen, essentially there's a dorsal respiratory group that's primarily made up of the solitary tract nucleus. If you hit that in the medulla, in the brainstem, you go to sleep, you cannot breathe. You will not initiate the breathing in sleep. And that's Ondine's curse. And everybody know who Ondine's is? Ondine is essentially Neptune. So I got a mixed marriage too. My wife's from Purdue and I'm from IU, kind of a thing. So she was in love with this human being. And he said, well, you know, I really don't like human beings. My parents really didn't like people from Purdue, but I learned to be accepting. And you all need to understand that. There's ethics and professionalism in life. So I was pretty lucky. So he was going to let her date the human being. But he said, if he's untrue, I'm going to curse him. Well, he played around on her. So the curse was, boom, you can't go to sleep because you won't breathe and you'll die. So that's Ondine's curse. Pretty cool. Anyway, so there are kids who are born with that. There are strokes that we call Ondine's curse. You hit that center, you may not be able to breathe without respiratory support at night. So you might need Trilogy, whatever it might be. You could also hit the ventral respiratory group. That's primarily comprised of the nucleus ambiguous, but as the years have gone by, we know they have the nucleus parambiguous, retroambiguous, the Boxinger and the pre-Boxinger complex, but essentially the nucleus ambiguous in the ventral area through the vagus nerves innervates the glottis. And if you have vocal cord paralysis, you got an obstructive event. So if you hit either of these areas, when you go to sleep and you don't have cortical override, where you can breathe because you want to, you could have either a central cause of a central sleep apnea, you can't initiate the breathing, or an obstructive sleep apnea. Everything closes down and gets floppy. And this is what it looks like. And this is something that we just republished that this year, and we updated everything. So here's the dorsal respiratory group, and gives you a side view right there, what the medulla is and where these respiratory groups are. A front view cut through, and then just a slice view. This is the nucleus tractus solitarius. Stroke that out, you have a central apnea. Stroke this out, the ventral respiratory group with the nucleus ambiguous goes to the glottis, and you have an obstructive apnea when you go to sleep. So that was one of the questions. Could that be the problem? Now, what implies that neurological dysfunction could cause an apnea is this case that we published a while back. And what we have is a stuporous young man. He has viral encephalitis. And in the MICU, what he does for fun is this. That's it. He's really close to dead. He's in stupor coma, just sort of sitting there looking like this. But he has normal sleep-wake changes. And we know that because we got an EEG on him. People with viral encephalitis, especially herpes encephalitis, often hits the temporal lobe, and we've called temporal lobe or partial complex epilepsy because so many things like the temporal lobe we call partial complex seizures, temporal lobe epilepsies. But herpes really likes this area, and sometimes you can be in what we call subclinical status, and you can be stuporous because you're firing off from this area. And it's often defined on the EEG as PLEDS, periodic lateralized epileptiform discharge. So we're not really quite sure what's going on, but during the day, he's having these long periods where his heart goes, and he'll get 20, 30 seconds of asystole. And he's doing this 10 to 20 sometimes a day. So the chief nurse is giving atropine over and over. They're getting little mini codes, and then his heart goes out of this. So they're wondering, because this is pretty funky actually. So Dr. Fincham, our epileptologist at the time, he was a great fellow that we named an award after him. He's passed since, but he had seen an association between the master organ, a seizure from herpetic encephalitis, and asystole, because the brain does control the heart to a great degree. So we were doing an EEG during a lot of these asystolic periods that they were given the atropine form, calling the little mini codes, and this is what the guy does. What did that look like? Did that look like a seizure? oh, my glottis is itchy. What do you think? Did that look like, what was I mimicking? An apnea. He was having apneic events. Remember what I said, if you suck down against a closed glottis, it's the same thing as if you stimulate the carotid. You can cause a parasympathetic vagal effect, and you can cause asystole. So be real careful if you look for carotid pulse. You can do that, the same thing. And that's what was going on. And what we were seeing, so this is a real long mixed apnea, but the chest is heaving. And what you start seeing during a 30-second epoch of monitoring in the MIC, we did a portable study, tachy, brady, and then about 20-some seconds of asystole. Would you think that 20-some second of asystole is a good thing or a bad thing? That's a good question. Is it bad or good? Because we thought it was bad. And again, we're not being strict scientists. This is anecdote. We don't have the N of 2000, but this is the difficulty with clinical research. How often do you see that? You probably see it more than you think, and the nurses see it all the time, but who's listening to them? Doctors got to work more as a team with nurses, with MAs, with PAs, and we're getting better at that. Without my technicians, because Zhong Ying's doing this study, not me. He's going, Dr. Teichen, come here. I think this is a parasympathetic overdrive. And so you've really got to work as a team, and everybody's got to be educated at a different level nowadays. So this has probably occurred forever and a day, and we see these recurrent asystolic periods, and seeing's believing. So this is during one of his mini codes. And in the ICU, as you all know, there's nothing more comfortable than a code that's run by a nurse who knows what they're doing. Although, hey, how do you make that thing work? It says, I don't want to work. What we've been seeing is what you often have to do, and I don't know if I can do that now, is go outside and go directly to the film. And it won't allow me to do that now, but what I do is if you all decide to stay at the end of this, when we're finished with this, I'll show you what the video looks of this guy doing, and it doesn't let me go reverse, so we'll go all the way through. That's always fun. Boom, boom. and actually we'll go through like this. And then I'll show you the video of this guy, but I just think it's too cool. The nurse is there, my technician's there. You can see him having paradoxical respirations. We all know what paradoxical respirations imply, but not everybody in the ICU on the team really knows what paradoxical respirations mean. And let's see what we got. And that's what would be his video. Let's take one more look at that. So we go to that. And I'll just show you that later. But she gets the atropine out, she treats him, she calls the code, he starts to breathe, and she goes, that is really strange. And he goes, what do you mean that's really strange? And he goes, well, he's not losing his blood pressure. Usually when I see people who have asystole, they don't have blood pressure head to perfuse the brain, the ischemic penumbra, the brain, the heart, everything is at risk. She sees the blood pressure keeps up. And what Verinda and I believe is the body tries to protect itself. You get a sympathetic overdrive, clamping down to the blood vessels, so you keep the pressure head to the ischemic penumbra of the heart and the brain. And then you'll see that, but I think what she says is profound. I don't understand that. Why does he keep his blood pressure head up when his heart isn't beating? So what we actually did with that is we treated the obstructive sleep apnea, and the asystole went away, immediately went away. Now, we were probably wrong about the herpetic portion of his viral encephalitis. There's probably some other kind of viral encephalitis because he lived. And 2 weeks later, he has CPAP on his face. And good old Midwest Iowa boy, he doesn't want a CPAP mask on holding him down. I mean, he's like 27, 32 years old, and he said, I'm not wearing a goddamn thing. I says, sir, you've got to understand that what you had in sleep is a hypoxemic event that is bad for the ischemic penumbra. And he went, you know, I don't like doctors at all. This is where all my relatives came before they died, and I'm worried you're going to kill me. We repeated the study, and what we actually saw, resolution of all apnea, including REM sleep in the supine position. So our thought was you could have a central event, and this is why we did the prevalence study in the MICU. If you downregulate the cortex, the respiratory system, the brainstem, because you have acute systemic illness, whether it's an infection, whether it's a heart attack, a stroke, renal failure, hepatic failure, drug overdose, you stop breathing. There's a dysfunction of the system. And what do people with alcohol overdose die of? The drummer for Led Zeppelin, they stop breathing. There's a lot of reasons in the MICU other than just straight lateral pharyngeal fat pads with obstructive sleep apnea causing an apnea. So it was reversible, implying that, maybe stroke could cause apnea, and if you see it and you can aggressively treat the person who might be trach, who might have intubation, maybe they could leave the hospital once they recover with aggressive therapy and not need CPAP, BPAP, or anything. So there are reversible apneas, and we kept him alive, I would like to think, because we treated him for a transient period with a CPAP therapy, and he didn't die, and this resolved. And all because I think that not having a heart rate for 20 to 30 seconds every few minutes is a bad thing. But I didn't make it science. I didn't say, well, let's do this. Let's get a lot of people like him, randomly, prospectively blind ourselves to treatment. It's awful hard to blind to CPAP on your face, but you can do a sham CPAP, as you all know, and see who dies. I don't think that would be ethical based upon what we're talking about. So, I mean, that's the difficulty. And the nurses say, God, you know this isn't good for you. My God. And my mom even said that. She's not a doctor. She's not a PhD. She's got 6 kids, and she's interested in what I do. And I presented this to her. She says, low oxygen to your heart and your brain, that can't be good. So, but we need to be scientists, so we're working on that. So, cause and effect studies are pending. Now, the second part of this lecture is congestive heart failure as a cause of apnea, because we know that there are systemic problems, drug overdose, and heart failure that can cause apneas. So we know that central sleep apnea with Cheyne-Stokes breathing, and there's a lot of theory behind this, can in itself cause apnea. So, but heart failure in general, when you're looking at Cheyne-Stokes respirations and central sleep apnea, there are the major predisposing factors that, as according to the Bible of sleep medicine, the new updated International Classification of Sleep Disorders, which parallels the International Classification of Diseases 10 and the DSM-5, etc. So we try to use the same common speak. But Important predisposing factors for central sleep apnea and Cheyne-Stokes breathing include congestive heart failure, number one. So 60% of all people with congestive heart failure, whether they're symptomatic or not, the symptomatic is they're in heart failure. And they may not complain of sleepiness, snoring, etc., because it's a relative thing. But 60% of them have some form of sleep apnea. 25 to 40% Cheyne-Stokes central sleep apnea, and if they're New York Heart Association classification 4, 80%. An acute stroke, 26 to 50% may, in some studies, have central apnea. For the most part, it's obstructive is what we've seen. About 70 to 80% of people with acute ischemic stroke have obstructive apnea. And then possibly renal failure. Metabolic disturbance can affect respiratory response to hypercarbia, hypoxemia that routinely occur with normal sleep. Oh, I broke the thing. Let's try this one. Boom. Okay. So this is the international standards for central sleep apnea and Cheyne-Stokes breathing. You have to have some sort of symptoms. Sleepiness, insomnia. There has to be a problem associated with untreated apnea. And then chronic heart failure, AFib flutter, neurologic disorder are all routinely associated with that. And what central sleep apnea, Cheyne-Stokes breathing is, we use a minimum of a respiratory cycle of a minimum of 40, usually 40 to 60 seconds. So there's a specific pattern of a crescendo, decrescendo respiratory abnormality. So what the thought is when we go to sleep, every one of us decreases our tidal volume. There is normally an increase of SaO2 by 1 to 2%. There is normally a decrease of SaO2 by 1 to 2%. And there is normally an increase, and this is pushing the limits, but some people say 4 to 9 millimeter mercury PaCO2. So 9's getting up there. We start using over 10, as a definition of hypoventilation in sleep. But there's a normal decrease in respiratory effort. Now, people in heart failure often have big, boggy lungs. Their lungs are full of water. So at the lung level, there may be stretching of juxtacapillary J receptors, which increases ventilatory drive. That increased ventilatory drive, Dr. White from Mayo and a lot of other critical care expert pulmonologists in sleep medicine say this is resetting the loop gain. And a simple way of looking at it, that increased respiratory drive says that if the loop gain, your tendency to overbreathe the hypoxemia or hypercarbia, is greater than 1, you'll breathe too much. So what we frequently see, the classic thing in Cheyne-Stokes breathing, central apnea, in a heart failure patient, when they get into N1, N2 sleep, the early stages of sleep, they have the most profound Cheyne-Stokes. When they get into the deeper stages of sleep, N3 and REM, it corrects. Because electrophysiologically, physiologically in the normal brain, in N3 and REM sleep, the hypercapnic, hypoxic responses are lower. The loop gain goes down to less than 1. There's not a tendency to over-respond to Mother Nature's normal decrease in oxygen by a little bit and increase in CO2 by a little bit during sleep. So this is a 5-minute epoch. We compress things to show you that this is at least a 1-minute cycle. These are like 1-minute cycles of classical Cheyne-Stokes respiration in a patient with heart failure in the transition from wakefulness to N1 sleep, where it's most classic. Oh, thanks for fixing that. I appreciate that. So one of the things to think is, so when you go to sleep and you have heart failure, you decrease your tidal volume. Your SaO2 goes down a little bit. Your PCO2 goes up a little bit. But you're set because of the stretching of the ductoglomerular elements in the alveoli to have a loop gain that's set higher than 1. You're going to over-respond. And what happens is because of a delay in circulation time, it takes a long time for this newly sleep-related, poorly oxygenated, hypercarbic blood to reach central chemoreceptors. So it gets even higher PCO2 than you and I might get, even lower hypoxemia, usually not too bad because most of us, unless we have lung disease, are playing off CO2 drive. And once it gets to these central chemoreceptors, it says, whoa, I have too much CO2, I better blow that off. And it's because of the loop gain, going to over-respond. And again, compounding that is a delayed circulation time. So by the time the well-oxygenated blood gets to the brain, you got good oxygen and you're hypocarbic. And you go, oh, I don't need to breathe for a while. Then you over-respond because your juxtaglomerular areas are stretched and you have a loop gain greater than 1. And that is defined, and my chief tech wrote this beautiful little, so sleep onset. Normally we decrease our O2 a little bit, increase our CO2 a little bit. Bottom line, in heart failure, because of all the things we mentioned, you tend to over-respond to this. You over-respond to this, delayed circulation, you get hypocapnia, and you set this vicious cycle where then you get hypocapnia, central apnea, boom, 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 boom. The loop grade is greater than 1. So the treatment is now very controversial. So we saw in one early study that CPAP often improved ejection fraction in patients with heart failure. Bottom line is, though, a lot of people in heart failure have not only central, but they have some obstructive events. And it may be we were treating the obstructive events and this had no effect on the centrals. But because of that, we had the famous CANPAP study. And it was stopped prematurely. They took all these people with heart failure and they put them on CPAP. Patients' ejection fractions, their ability to walk 6 minutes, their quality of life was all improving, but the people who were improving were dying earlier. So they stopped the study and they said, well, what could be going on? They said, well, maybe the inspiratory pressure and the expiratory pressure, which are equal in CPAP, is decreasing venous return. And what we're doing is not bringing any blood back, preload reduction, and we're killing the patient. So we often try to avoid giving a CPAP or an EPAP, if we're using a BPAP machine, of anything greater than 15 because of what we suppose. It's not really written in stone there. And then Varind and Javahari looked at a post hoc analysis of this data and suggested the mortality might be lower in a subgroup if we were able to reduce the apnea-hypopnea index to less than 15, less than moderate apnea. So a little bit up in the air. So this is the Shane Stokes central person. We got CPAP on at 18. Really not where we want to be. It ain't doing anything for the central apnea. Just an example of that. Now we had adaptive servoventilation. So essentially, if you have an obstructive event, it will sense that because it is going to look for minute volume, the normal minute volume of this patient, depending on what machine, Respironics or ResMed, over a 4 to 12 minute period. So it wants to deliver, and you're setting the pace. Shane Stokes, it goes, well, they need this much minute volume. I'm going to adjust that, but if I see an obstruction, it will automatically increase the EPAP to open up the hole. And usually just to a minimal level because of what we know of the pathophysiology of the normal apneic, obstructive apneic. So then, during the Shane Stokes element, when they get the central, the IPAP will notice it's a central, and breath to breath, it will notice that and it will increase the IPAP to what it needs to start correcting and breathing during the central element of the Shane Stokes respiratory cycle, but during the hyperpnea, it lays back. It doesn't touch that. So it only comes in when it needs to. And it will gradually, over 12, 20, 30-minute period, recognize the normalcy of the patient, and it will increase the respiratory rate. It's on auto on that, so that it delivers a wonderful, persistent CPAP volume and supports the respiration with a little bit of IPAP as it's needed, and it decreases loop gain less than 1, is what the theory is. So this is a person starting on AVAPs, adaptive servoventilation, at the beginning, and about 4 or 5 minutes later, still N2 sleep, same stage of sleep, 5-minute epoch, starts to improve, but you still see that underlying pattern. And then after about another 4 to 5 minute period, this is what we see, minimal fluctuations in IPAP, just to maintain with a backup respiratory rate adjusted to the patient's own breathing over a 4 to 12 minute period, depending on what machine you're using, of normalcy. Now, if they wake up, or if they go into REM or N3 sleep where this resolves, it takes a while then to catch back up. But it seemed like the wonderful thing to treat the patient with. And in general, like I mentioned, people with congestive heart failure, to support the dying myocardium, the sympathetics are way up. And multiple studies have shown when you're using adaptive servoventilation appropriately, echocardiographic improvements, lower NYHA classifications, improvement left ventricular function, cardiac sympathetic nerve activity, What other stuff do we have? If you use it in combination with pharmacotherapy, everybody's on pharmacotherapy, increased left ventricular ejection fraction, reduced mortality in the one study. And let's see, versus non-treatment. This is the New England paper from just last month. So this is what Vern was on. So what they actually did, they put AVAPs on all comers, but they set the setting, they set the pressure support minimum of 3. We think that's where the problem is. But they were killing people. What they were seeing is that the people who were on AVAPs compared to the other 600, 700 patients, so big control groups, they had a significantly higher mortality from any cause and significantly higher cardiovascular mortality. So the American Academy of Sleep Medicine came out with this in August, knowing that this was before the publication even came out, that adaptive cerebral ventilation therapy in chronic heart failure is contraindicated if you're NYAH 2 to 4 and you have left ventricular ejection fraction less than or equal to 45 and moderate to severe predominant central sleep apnea, meaning a central apnea-hypopnea index of 15 or greater. And this is based on consultation and regulatory authorities and expert opinion, not prospective double-blind treatment versus not treatment cause and effect study. But it's where we are, and you have to be careful. Clinical judgment, you can utilize adaptive servo if you think the obstructive elements underneath are the most dangerous thing. But it's the controversy. And I pretend like a lawyer's behind me every single time I use one therapy. You better be able to define this very well if you're going to slap adaptive servo. And the learning curve's catching up with us. You just don't open up a lab down the street and say, and we got great lab down the street, in fact, if Tim's here today, but you just don't open up a lab not knowing what you're doing and put adaptive servo ventilation on somebody. You can kill them. We know from the CAMPAP study, if the pressure's too high, CPAP can kill people. They have to be used wisely. 4 Percocet every 4 hours can take your pain. 5, you will have liver failure and you can die from that. This is a drug. This is to be used appropriately. What if you can't use adaptive servoventilation and you can't justify it to yourself, your patient, or your lawyer? Because we have to be that smart. Oxygen, supplemental oxygen. And I don't know how many of you have seen this, but it doesn't work all that often. But what we think, supplemental oxygen may attenuate the hyperventilatory response to the changing PaCO2, just enough to reduce loop gain to less than 1. So this is our guy, just a couple of weeks ago. Shane Stoke, but mixed in there, that's a central apnea-hypopnea index of 80, an obstructive apnea-hypopnea index of 20, predominantly central. So he tried CPAP right here. He ripped the thing off, said, this sucks. And it wasn't taking care of it anyway. And he says, I'm not going to let you do anything else. My cardiologist had me on 4 liters of oxygen, put him on 4 liters of oxygen. His SaO2 is 100. Resolution of all events. I don't see it that often, but it's a great consideration. Central apnea, you can consider oxygen, CO2 therapy, a little bit dangerous, increasing the dead space, but every patient's different. This is a different kind of sleep apnea than emergent, complex, or drug-related sleep apnea. And that's why we're concentrating on this today. It gets complicated enough. So this is our guy before stage 2 sleep, wonderful, beautifully, morbidly fascinating centrals. Oxygen, it went away, but still see that pattern. It's still not normal breathing, but no DSAT, 99. He was very happy. And then we like Christmas cards from patients. So I had a happy patient. That's the bottom line of medicine. So I hope what you got out of this today is stroke and heart failure can predispose to a variety of sleep-related breathing problems. We just hit the tip of the iceberg today. Stroke, OSA, central sleep apnea, Shane Stoke breathing is still possible, but in heart failure, central sleep apnea, Shane Stoke breathing, and occasionally with underlying obstructive apneic events, we have to look for and treat appropriately. We know that untreated OSA is a stroke risk factor, and we know that we may be reducing mortality and morbidity in both these disorders, but you have to be very cautious with what PAP device, supplemental oxygen, increasing dead space, CO2 therapy when you address the patients. So much more is happening. The fund of knowledge and the learning curve is going so much up that I was telling my chief technician in my text the other day, we got to be proud of what we're doing. This is not on-the-job training anymore, and we have a precious commodity. We don't want to kill with kindness. We really have to know what we're doing. And this data is just from last month. But this is what we had today. Hey, do you think I can get that video? I really think it's pretty cool. I lost my time there. I started. So he is right. Asystole. Oh, then this guy is ID safe. So we've removed all identifying factors from this guy, and I go, okay, yeah, recommended settings. Oh, great. And then, oh, there he is. He's hidden behind there. And click on him once. Okay, here's the guy. Now watch his chest. Who else looks for paradoxical respirations other than us? And you don't have to have loud snoring when you have apnea, because when you have apnea, there's no airflow turbulence. So watch his chest and abdomen heave. Now he stopped. So there's a central component of the mixed. And there's the paradoxical respirations. Abdomen's out, chest is down. Isn't that morbidly fascinating? And who else is going to enjoy that but us? My kids didn't get a thrill out of this at all. But paradoxical respirations. So the nurse is smart. She knows something going on. She's seeing asystole. Watch what she does. Just cool as can be. So he's having the obstructive element. She's calling the code. Just getting the fellas over there. Yeah. And this is atropine she's going to get for like the 12th time today. And then this is just brilliance that she says, I think. There's the atropine. There's my tech. Blood pressure. Never loses his blood pressure. Actually increases. And I think that's the protective phenomenon. We presented this at Dresden about 10 years ago. This is a different animal. And if you look at the clinical environment, it can lead you to better therapies. Well, that's all I have today. Thanks for having us. Yeah. Oh, yeah. Now the criteria. Oh, so have you ever called Medicaid, Medicare? Hours and hours? And if you don't sound like a complete idiot, because many idiots have called them, and they're my relatives and my friends and me on any occasion. But once you really talk to them, they go, oh, you know what you're talking about. Because people yell at me every day because we're not justifying therapy. You have to make the standards. So with Central, you have to follow quote-unquote hypoventilatory, and it depends on if you're talking polysomnographic ease, pulmonary critical care ease, or cardiology. So the three big, when you look at and go to your LCD, not the national CMS. The national CMS is superficial. It will not take the LCD. So the local demands for oxygen are most of the states in the United States. So when you go to that center, you put the thing and say, yeah, I agree to whatever you say. And when you look at it, there are three big groups: sleep-related groups, cardiology groups, pulmonary groups. So we have this fellow was able to get on 4 liters of oxygen because he's cold pulmonale. Cardiologist has to be the physician or the expert who has done the face-to-face, who documented the PaCO2. Usually you need a PaCO2 with the PaCO2 either greater than 45 or 52, depending on what category you're in, so it has to be elevated. And you have to direct this within a 1-year period based upon those findings. So you have to be an expert, it's your face-to-face, and they put him on 4 liters of oxygen. If he has pulmonary hypertension with hypoxemia, then it has to be the pulmonary specialist who used PaCO2, FiO2, best corrected with another gas and directed it using those. In sleep, what you need, if it's central, and this is where we couldn't treat him with oxygen, but our team, our cardiologists could, He has to have an SaO2 less than or equal to 88% for greater than or equal to 5 total recording minutes. Now, why is that not minutes of sleep? They don't care if you're hypoxemic awake and asleep, and many of these people are hypoxemic awake and asleep. Obesity, hypoventilation syndrome, COPD, all different categories, and you start to cry after a while, but if you take 2 weeks to edit it, and your students say, thank you for doing that, and they give you a Christmas card, then it's worth it. But we have to know that. So I could not institute therapy because the SaO2 was not less than, and my neon coding system will gather that for me. I'll have the exact amount of time less than that, but the Cheyne-Stokes element, they don't desat as bad as an obstructive. And in fact, one of the theories is treat the obstructive element, leave the Cheyne-Stokes alone, which I don't quite believe, because it's decreasing the sympathetics during that respite period. When you have the central, many people believe the sympathetics go down, and that's why Cheyne-Stokes is occurring. It's therapeutic. And are we killing the patients because we're fighting that normal Cheyne-Stokes? I don't quite believe that. But we'll find out. And we want to make sure that we're doing the smartest thing. I'm really aggressive on treating the obstructions, but you have to follow the standards, or else, I don't know if Lisa's here today, but she'll say, you didn't follow CMS. They're not going to get this. They're not, so we can have the greatest ideas we want in the world, but if we can't justify the therapy to third-party payers or Medicaid, Medicare, they're not going to get our therapy. But a great question. Anything else? I think I've outdone my welcome today.
Thank you very
Thank
much,
you.
Dr. Dyson.